Uh, Good morning, friends. At the outset, I would like to thank Professor Azad for giving me this opportunity to be part of this instruction course here. I'm going to talk on the laser treatment of retinopathy of prematurity. Basically, we'll touch upon a few of the things as far as the laser treatment is concerned. And we are all aware at this time that laser treatment earlier than threshold ROP has almost become the standard of care after the ET-ROP study. So, in fact, we need not even probably know in today's time what is threshold disease because the indications are like this. So, I think we are treating more babies, and that is what is happening. The plus disease is most important. So, in zone 1, if you have a plus disease, so you treat everything. Photographs which were in the original publication, this were given to me by Michael Spiro that time, and these are the different 3 patterns of APROP which you might see. So you have brush-like, or you have flat new vessels, or you may have something which is just getting raised here. So these cases will never, as he already emphasized, go into any stage. So once you see any of these, just take them. And the problem is, in our country, probably even what we have seen, 1/3, maybe sometime even more cases are of APROP. So I think you need to recognize this condition more and more. And the rationale for treatment is that stimulus comes from the retina, which is totally avascular, and that goes all around like here. And this one is very, very posterior. This is not even like a stage. This is something has been stuck here. Even the vessels are going a little beyond here. And you have to ablate everything from here to ora serrata all around. And that is what is very important, and that's how you're going to. So at present, we all know that we deliver this through the laser indirect ophthalmoscope. Earlier, then I already mentioned, then threshold ROP, and do it all around. You need good pupillary dilatation, nicely dealt by Parijat, and you need appropriate monitoring by a neonatologist, pediatrician, or anesthesiologist. Because anesthesiologist, if you are doing this in a hospital, which is like an eye hospital, so you don't do it without that. Otherwise, we mostly treat this in the NICU area, or of course if you have an anesthesiologist monitoring. And most of the time you need a monitoring, you don't need GA like most of the time we need used to do when we did cryovaccine old time, we required a GA. So what are the requirements? You need laser indirect ophthalmoscope with 20 or 28 diopter lens, eye speculum and infant scleral depressor or Vectis, which I still use till today, and topical anesthetic drops, some artificial tear and normal saline to keep the cornea wet. And you need to do it in a confluent manner. That is the way you do it, so that ultimately everything becomes one and the disease regresses. So if you do then less than half burnt width apart, 90% would attain favorable outcome for the indication which I have already shown earlier to you. So we don't call them before 1 week. Usually we give some topical antibiotic and steroids for a week, and here detailed examination we do after 1 week for these children. And what you aim for, you need to have something like this. You have a disease here, plus disease would regress totally. This is in 2 weeks we have taken picture. These vessels straighten up, they are no more dilated, and that is what would happen in 1 to 3 weeks time after laser. So, and this is another example, same type of a case. You can see this is a disease which is in zone 2 posterior, and everything, all these vessels, they have straightened up, they are thinner, and so you have an excellent treatment. And you can also do it inside the incubator wall. If you have an unstable baby, very sick baby, which can't be taken out, you can do both screening as well as treatment inside. I think many of you have seen this clip many times. I think this is when Anand was with me in PGI. You can see we could treat this baby through the wall of incubator, just rotate it around, and you can do with the same parameter as you did any other baby. And we have done this many times. And this also can be done for babies. Suppose your baby has gone into apnea or something, has gone sick. So you can later on maybe do it inside the incubator, maybe next day or whenever, so that it's they have also more confidence. Second problem in our country is we don't have a diode laser everywhere. And every time Western countries told us that it is a diode laser which is required, which is not true. This also happened when Anand was with me. We collected these cases because our diode laser conked off, so we treated all with 532. And we just compared. There was no difference. Even if there was tunica vasculosa lentis, vitreous or preretinal hemorrhage, we could get exactly similar results in both the groups. And this was published in British Journal in 2010. So if you have a 532 laser, you can use the same laser for everything. So you need not worry that you require a special diode laser. I think you can see here, this is a APROP, and these are the kind of baby, you'll be surprised, this baby was 2 kgs. And these are some of the babies, higher birth, they come from outborn, maybe they are using totally 100% oxygen, but they do regress if you do good treatment. And this is the other eye of the same baby, but it regressed, both the eyes regressed. And this is the same picture which I have shown you earlier, and this is a posterior zone 1 ROP. The vessels, they are not even growing beyond this area. And this is something very funny. In fact, this thing folded over, and there was an unfavorable outcome. And this thing folded over. And of course, we were lucky to have a favorable outcome in the other eye. And this kind of a picture, this was so taut. Even if I thought of doing surgery here, you can't do anything about this one. This is absolutely like a... So we looked at some of these cases, because the PACE cases, this we published in American Journal in 2013, that which are the cases of these APROP going into retinal detachment. So gestational age less than 29 weeks, and posterior zone 1 ROP, which we see very often. I think you have to be very careful. Maybe we need a combination treatment here in these cases. And if you have a lot of pre-retinal hemorrhages or a need for a repeat laser treatment. And this was very important. In fact, new onset fibrovascular proliferation after laser treatment. If you have this, watch them very closely. And these are the cases now, at least at this time. We know if we have that and it's progressing, we take them for lens-bearing vitrectomy. It's very, very important. And of course, if you, in cases which are milder, you have 100% success. And here you may have around 90%. It was like old threshold type. APROP still maybe anywhere from 70-75% up to 80%. And if you have a 4A, it comes down to 30%. So then probably you need to do in addition. But the problem is this only. They come late to us, like this one, outborn, did laser. It went into 4B. Of course, we had to do later on lens-sparing vitrectomy. Another one, didn't send it. It is already a narrow arcade and lasered like this. And they are sending the baby later on, and you have a narrow arcade like this. He was lucky that this eye, at least one eye, it separated after we treated very aggressively. Other eye still is very narrow and the vision is very, very poor. And somebody went overboard here. I think I always get scared of this kind of a picture. So don't even do that. Don't go to other side. Don't burn through the fovea. I think it's very important. You have to demarcate and then do it. I think this is very nicely shown by Parijat, angiography. He has shown already that these ones are avascular totally. So you need to go inside them and treat them. Of course, we did that in this particular case. Despite that, disorganized. But you see, I have not shown the results. We did lens-sparing vitrectomy. This eye has done very well. Another one, you can see stage 3, posterior zone 1 here. And we did laser and we went in for laser. I think we did laser here twice. But you can see, that is what I was showing. That is what I told you. You have a picture like this from that. Now don't wait. Now you can see this is a classical example. We waited and it landed up like this. 4B here. And so you will have a much worse prognosis. And this is a very important article. I give all the credit to Subhadra. Once he said, we see all kind of lasers being done in this country. This is in Indian Journal in 2010. Go through this and you will realize that how you should be doing laser for retinopathy of prematurity. So I would like to conclude here that treat ROP as per the study, ET-ROP study recommendations, and of course keep in mind this AP-ROP promptly with confluent laser. That's very important. So if you don't do confluent laser, it's not going to work. And the laser treatment is standard of care at this time, even for ROP. And laser treatment is also possible inside the incubator through the transplant wall in unstable infants, and around 90% of them would show favorable outcome with laser treatment alone. Thank you very much.